Good morning or good afternoon. My name is Nicholas Thompson, giving a talk today on common sports injuries and treatment methods. I work with Warren Clinic Orthopedics and Sports Medicine. I've been doing that for about 2 years now. Basically see all primary care sports medicine and non-operative orthopedic care in our office and manage and treat those conditions. So we'll get started here today. First off, I have no disclosures. A few learning objectives for everybody today. First, we will review some anatomy and biomechanics involved in the joint examination. Next, we'll also discuss some common injuries that you'll encounter in your primary care offices. And then we'll also advise you on when you need to refer to the specialist, so things that get on to the orthopedic specialists from the office, things you're comfortable with treating. Also become comfortable in understanding these common injuries, and which will allow you to treat them in your office so you can capture that revenue and also take care of your patients without needing to send them to me. So we'll kind of just go through some general conditions. I'm going to kind of break this talk down by joint-specific issues. So we'll kind of start from the top of the body, and we'll move our way down with some common injuries here. So first off, we're going to talk about the shoulder. And with every joint or orthopedic examination, I like to kind of talk about the underlying anatomical structures, because that kind of guides and helps us make a lot of the decisions as far as the injury or the mechanism of injury of what's occurred, so we can better diagnose and treat those things. So with the shoulder exam, obviously when they come in, we're typically going to initiate evaluation with a palpatory examination. So there's a few structures that I always palpate on a shoulder exam. So kind of see here on the slide, we look here from the anterior side of the body, starting in the more medial section with the sternoclavicular joint, moving down the clavicle over towards the acromioclavicular joint, and then the acromion wrapping around the posterior side of the shoulder, and then also the coracoid process, which is an attachment site for several muscles that can cause some pain, and then over onto the humerus with the greater tubercle as well as the lesser tubercle, where we'll see attachment of the rotator cuff muscles, and then down in the bicipital groove where the long head of the biceps tendon lies, which can also be a pain producer for patients. Also over here, there's going to be the overlying musculature that you're going to be able to see. So you've got the rotator cuff tendons and muscles in the shoulder. You've also got numerous ligaments and biceps tendon and other muscles over and underlying this area as well. The other things we see is the subacromial bursa, which can also be a common source of pain for patients. So just kind of overviewing that, again, there's basically 3 joints in the shoulder that we evaluate. You're going to have the main shoulder joint or the glenohumeral joint, and also the sternoclavicular and the acromioclavicular joints in the shoulder group. Muscle groups, we talk about the rotator cuff, the posterior shoulder wall, as well as the chest wall, which have some overlying muscles as well that we can see some injuries with. So again, kind of my palpatory exam, I start from the sternoclavicular joint, move myself down the clavicle, and go to the acromioclavicular joint. We're talking about the coracoid process. Those muscles that attach there would include the pectoralis minor, coracobrachialis, short head of the biceps. It can be a very tender location for people in general, even if they don't have an injury there. Get greater tubercle of the humerus with the 3 of the 4 rotator cuff attachments. And then posteriorly, I wrap around and also palpate the acromion back around to the spine of the scapula. So with every joint examination, we're going to talk about range of motion. So there's always going to be a normal established range of motion that we will see in patients, and we always want to make sure that we're documenting any kind of variations or abnormalities with these range of motion. So typically for the forward flexion for a patient, you usually get about 180 degrees of forward flexion. Extension usually goes from about 0 to 60 degrees. Abduction or away from the body would be about 0 to 180 degrees. And then when we talk about external rotation, you can evaluate that in two different planes. You can evaluate it with the arm at the side of the patient and having them externally rotate out away from their body. And you can also evaluate that at 90 degrees and have them externally rotate up and away. Internal rotation is also typically evaluated with two different methods or terminologies. You can have the patient internally rotate behind their back to mark the spinous process level that they're able to obtain, or you can also have them internally rotate with the arm abducted to 90 degrees to evaluate that internal rotation. So typically patients that come in with shoulder complaints are going to have some variations of abnormal range of motion. Typically you're going to see a decreased internal rotation. That seems to be the most common. So patients will state they can't reach behind their back. They can't, female patients will be stating they can't undo their bras. They can't put their shirts on. Those are going to be some kind of common complaints that you'll hear as far as the range of motion limitations for these patients. So I briefly touched on one of the major structures or muscle groups that we evaluate in a shoulder examination will be the rotator cuff. So harkening back here to your anatomy and medical school days, we've got the four muscles: the rotator cuff, the supraspinatus, infraspinatus, teres minor, and the subscapularis. Again, makes the mnemonic of SITS. Three of those muscles, the supraspinatus, infraspinatus, and teres minor, are going to be attaching to the greater tubercle, while that subscapularis tendon wraps down and attaches to the lesser tubercle on the humerus. Now, supraspinatus is mainly involved in the abduction or moving away from the body of the arm. The infraspinatus is mainly involved in some external rotation. Teres minor also aids in that external rotation. And then the subscapularis is the one with internal rotation and adducts or adducts the arm there. So, and as you can see on this graphic here, this kind of shows you how those tendons insert onto the tubercles there, with the bicipital groove or the intertubercular groove running down the middle of the bone there. So obviously with any joint examination, we're going to talk about some special tests. Shoulder, there's quite a few of these, and we'll go through some of these here and talk about those. So again, evaluating the rotator cuff, we're wanting to evaluate those individual tendons to see if we get any weakness or pain when we evaluate those specific tendons. So the first one would be the supraspinatus. So you can evaluate that with the empty can test. I'm sure many of you have utilized this test in the office. Basically elevate the arms to about 90 degrees and then internally rotate the arms with the thumbs pointing down, and then ask the patient to resist your downward pressure. Now this is isolating of that supraspinatus tendon, so it's very helpful in evaluating for concern of rotator cuff tear. Supraspinatus is typically one of your more common tendons that's going to be injured in rotator cuff pathology, and so it's a vital tendon and muscle to evaluate in this exam. The one thing I always say is on this the empty can test, you want to make sure you're staying in the plane of the scapula. So when you do bring the arm elevated, you want to make sure you keep that in the same plane as your scapula, not bring it too far into the center here. Kind of a variation of the empty can test is the full can test, and that's where you would just flip the hand up as far as externally rotating this, and then have the patient resist that maneuver as well. Infraspinatus, basically for that one, you put your arm by the side with the elbow flexed, and then you're going to have them resist your force by pushing in towards their stomach. Then there's the teres minor, again, similar evaluation as far as resisted external rotation. And then the subscapularis, so we look at with the liftoff test or the belly press test to get further evaluation if that tendon or muscle is injured or dysfunctional. Also with shoulder evaluation, you do have to check for a few other things. Some common things that we see as far as pain producing in the shoulder are going to be shoulder impingement. So many patients have subacromial impingement of the shoulder, which is going to lead to quite a bit of pain, especially with repetitive overhead task. So the NEARS and the Hawking's test are both helpful in a clinical examination to evaluate for these issues. The NEARS impingement test, basically forward flexing the patient's shoulder near their ear. That's kind of how you can remember this test. So you want to bring their arm up and near their ear in a forward flexion motion. And then if positive sign would be if they have pain reproduced with that maneuver. Subsequently, the Hawkins impingement sign is another sign for shoulder impingement. That's where you elevate the patient's arm in flex position about 90 degrees and then have them internally rotate the arm down. If they get reproduction of pain in their shoulder, that would be a positive finding as well for shoulder impingement. Also in the shoulder, there's the biceps tendons, typically the long head of the biceps tendon. So there's the Speed and Jorgensen's test. So I basically use those as a monitor for biceps tendonitis. And then you have the person basically resist an internal rotation with the elbow flexed, or then you can also have them resist basically a flexed arm and have them resist your force down like this to evaluate if there's having pain. A positive sign would have reproduction of the patient's symptoms here in the anterior shoulder. The apprehension relocation test is typically used more for shoulder after shoulder dislocations or for shoulder stability purposes. For these, I have the patient lie on a exam table. I'll have them scoot their shoulder off the affected shoulder off the side of the table, and then I will externally rotate them back. And then if they feel, you're looking for a symptom of instability, so you'll ask the patient, does this feel like your shoulder is going to dislocate? If they answer yes, then with relocation, you want to apply a anterior force to the shoulder and reproduce that maneuver and see if that improves their symptoms. And that would be a positive finding as far as evaluation for instability of the shoulder. Cross-arm test, I just have the patient reach their arm across their body. This is checking for acromioclavicular joint issues, arthritis, sprains. You can also have the patient place their hand on their opposite shoulder. That also applies the same motion that you're looking for as far as evaluating that area. The Apley scratch test, so that's again checking for internal rotation. So if you have them come reach from behind their back and try to reach up to their highest spinous process level and document that as the level reached. And typically in patients, their dominant arm will be their least, or they'll have more restriction with that side. So it's not uncommon to see a right-handed individual that will have less internal rotation on their dominant or right side versus their left side. But you can also use sides as far as comparison to see where they're able to reach. So we'll start talking now about some injuries. So I've kind of divided these up into traumatic versus overuse type injuries to try to better help understand injury mechanisms and reasons for pain. So first injury we'll talk about would be the AC separation or shoulder separation. This typically occurs after somebody's fallen onto the shoulder. You see it a lot in contact sports where somebody falls and lands on the shoulder. This also can be seen in patients that fall on an outstretched arm. They typically come in with localized pain over the shoulder. Also have some pain or swelling as you palpate over the acromioclavicular joint. Always, with orthopedic injuries, we always, typically recommend an X-ray. So if you dig in an X-ray with the shoulder separations, would vary on degree of severity as far as the injury goes. So for the shoulder separations or the acromioclavicular separations, we grade these into 6 types. So broken down, type 1 and 2 would be whether you see type 1 has no step off on X-ray and there's just pain over the shoulder. area as far as the AC joint. Type 2, you would have less than a 50% step off on the AP lateral of the, or the AP x-ray of the shoulder there. Type 3, you're going to start seeing a greater than 50% step off, and even occasionally the clavicle will be dislocated. And then your higher grade injuries, the 4, 5, and 6, you're going to start getting either posterior displacement in the type 4. Type 5s will have a greater than 100% dislocation, and then type 6s, the most severe, will actually have the clavicle displaced under the coracoid process. And as far as advanced imaging on these, it's not necessary initially, especially in these lower grade type 1 and type 2 injuries. If you do get MRIs on the lower grade injuries, you'll typically see just that the ligaments are intact, so both the acromioclavicular and the coracoclavicular ligaments in the area there. Type 2s, you may see a little bit of edema, and the AC ligament may be torn as well, which is allowing for that step off. And your high grade injuries are going to typically get more damage to the ligaments. So type 3, you'll likely have some tearing of both the acromioclavicular and the coracoclavicular ligaments, and then that elevation will also be noted. And then in the higher grades, both those ligaments will be torn, and even potentially have a posterior clavicle as well. And we talk about treatment with these injuries. Like I said, these lower grade injuries would be something you guys could definitely treat in the office. It's really symptomatic care. Place them in a sling for a short period of time, ice, rehabilitation, anti-inflammatories. And usually people do really well with these and don't require any further intervention as far as treatment goes. With some of the lower grade injuries, they can return in 1 to 3 weeks to play. Basically, evaluation post-injury would just include another shoulder exam prior to them returning, and then making sure they have intact strength and range of motion that's equal to their contralateral side, or if you've seen them before, their baseline. Typically don't recommend any injections in this. That's kind of more for a pain control type thing, and I don't usually do those. In your higher grade injuries, again, you're going to want to put them in a sling, so the type 3 you'd sling. These are kind of a gray zone. These some people treat these operatively. A lot of them are treated non-operatively as well. And then the 4, 5, and 6 injuries where you're starting to get more displacement, those likely require surgery, and return to play guidelines would be much greater at 4 to 6 months. Another common traumatic injury that we see would be the shoulder dislocations. That's going to be an anterior shoulder dislocation. Typically, the person will have some kind of fall, or they had some forced abduction, external, or forced hit when they had their arm abducted and externally rotated. So you see this a lot again in contact sports. Typically have pain. The arm will be held kind of in a adducted, internally rotated position. They'll have very difficult time maneuvering the shoulder. You don't really need an x-ray to diagnose this. You can kind of diagnose this clinically, and really the treatment is a quick relocation of the dislocated shoulder. MRI is really not indicated, but it can be helpful afterwards, after you've reduced the shoulder, to determine if there's any other subsequent pathology in the shoulder. So again, really the treatment is to reduce it, and then return to play is 1 to 3 weeks. Again, you're going to be reevaluating them and seeing how their strength goes, if there's any other concern for other ligamentous or tendinous or cartilage injuries, obviously proceeding with an MRI to evaluate that. And then, we'll talk here on the next slide about surgery versus rehabilitation. Several techniques out as far as what people are doing. A lot of them basically encompass some type of external rotation, abduction maneuvers, and that's just basically where you're going to get that shoulder to get back into the joint and reduce for you. So there's the traction, countertraction, Stimson maneuver, which is where you have the patient lay on a table with their arm hanging off the table and apply a weight to that to just let that gradually pull down the shoulder. It also will release some of the muscle contractions. You've got the scapular manipulation, external rotation, like I said, Milch and spasso techniques as well. So it's kind of just on your preference. You can pick one, and then if you utilize that, that's the one you'd use. Just continue that, and typically the best reductions occur as quick as you can do them. The longer you wait, you're going to start getting more muscular contractions. That's going to typically make the reduction a lot more difficult. So signs of a successful reduction are going to be you're going to actually feel or hear the clunk of that relocation. They'll get relief of the pain, and they'll be able to move their shoulder again. So as far as management goes, we do talk about non-operative and operative management. So typically with a first-time shoulder dislocator that doesn't have any radiographic signs of a fracture, you can typically treat these non-operatively. So you'd rehab the shoulder and get their strength back and return them to play. Potentially, some people put them back in braces so they have less chance for secondary dislocation. And some people return without need for that. So people are going to be at higher risk for the secondary dislocations. Going to be the less than 20-year-olds, males, contact sports. If there's a hyperlaxity diagnosis, or if you've started developing some glenoid bone loss. So typically, as the shoulder dislocates anteriorly, the humerus basically is chipping at that glenoid bone, so you can actually sometimes see an injury on x-ray, or people, if they've had multiple dislocations, that glenoid bone will become where it's not holding the shoulder in. You'll get the dislocations much easier. And then physical therapy and then bracing, as I touched on a second ago. Move on to some overuse injuries. So really, one of the main things I see in the office and in the clinic would be, related to these overuse type injuries. Rotator cuff tendonitis, which I would always also clump in with subacromial bursitis. So you're going to have pain with overhead motions, decreased strength. Typically see these in patients with overuse or repetitive type job requirements, or if they play sports that require overhead motion over and over, volleyball players, tennis players. So particularly the patient will have pain. They'll have the positive Neers and Hawkinson like we discussed. Always get an x-ray. You can look for subacromial impingement. You can the scapular Y view is very helpful at looking at the type of acromion. So as the acromion wraps around and comes to the clavicle to make the AC joint, typically you have 1 to 4 types of acromial types. So most patients that you see are type 1, which is kind of a flat bone. Type 2s kind of start to curve down. Type 3s are hooked, and then type 4 is just very severe down into the that subacromial space there. Sometimes MRIs would be indicated, however, if their strength's intact and it just seems more of and there wasn't an injury, it seems more of just a overuse type thing, then typically don't jump to MRI. Another common overuse injury is a biceps tendonitis. That's again on the anterior shoulder. Again, usually an overuse or repetitive type problem that people have had. They'll have tenderness palpation over the bicipital groove. They'll have a positive Speeds and Yerkeson's test, and typically don't need an x-ray for this, but we x-ray most of the patients we see, so you'll normally not see any positive findings on that. And then again, MRI is not indicated. As far as treatment, rotator cuff tendonitis, and bursitis, anti-inflammatories, physical therapy. They make some topical anti-inflammatories as well that some people utilize for treatment. And then obviously a steroid injection in the form of a subacromial bursa injection. For those, I approach the patient from the posterior side of the shoulder. I use some lidocaine to anesthetize the skin, and then I take a mixture of lidocaine, marcaine, and I use Depomedrol myself and place that into the subacromial space or bursa for the injection. Now I do also utilize some ultrasound guidance for these. However, typically I do these without ultrasound guidance. It's more of a palpatory injection where you aim towards the coracoid process anteriorly with your needle. Typically, I give some exercise as well as far as rotator cuff strengthening for the patient to begin, a week to 10 days after the injection. And then if the patient's still having persistent pain or symptoms for about 6 weeks, and we consider getting an MRI. Biceps tendonitis, again, they make Voltaren gel or diclofenac gel is very helpful. It's a very superficial tendon, so they can rub that on there. Ice is helpful. Oral anti-inflammatories, physical therapy. For these, I don't inject. There's a risk for rupturing the tendon if you do inject a steroid in this location, so I don't perform this myself. Moving down the body into the elbow. Again, we'll kind of talk about the palpatory examination. So the elbow, there's several things you want to palpate while you're examining. So the first would be the medial and lateral epicondyle. These are important structures. They're a common source of pain for patients. The common flexor tendon inserts onto the medial epicondyle, and the common extensor tendon inserts onto the lateral epicondyle. And again, these are very common for overuse type injuries. There's also the radial head, which can be painful for patients, and then also the ulnar nerve, which sits in the cubital tunnel between the medial epicondyle and the olecranon. Again, range of motion with the elbow, so we talk about flexion, 0 to 150 degrees, extension, 0 to 150 degrees. Pronation, typically you can get somewhere between 75 and 90 degrees, depending on the patient, as well as the same with supination. Testing on the elbow, so varus and valgus stress, similar to a knee exam, so we're testing those radial collateral and ulnar collateral ligaments. There's also maneuver called the milking maneuver, which also tests that medial or that ulnar collateral ligament in patients. It's a common place of injury, especially in your athletic population. Tinel sign, so any kind of tapping over the nerve, so there'd be the ulnar nerve there and the cubital tunnel that you can tap over. A positive sign would be indicative with numbness and tingling into the fourth and fifth digits of that hand. And then one test that is also important to do, especially in a traumatic injury where there's a lot of bruising in the elbow, would be the distal biceps tendon evaluation with the hook test, basically palpating in that antecubital fossa to make sure the distal biceps tendon is intact. So we'll talk about a few traumatic injuries with the elbow. So like I was talking there, the distal biceps tendon is an injury that we do see. Typically someone will state they hear a pop. They'll typically have quite a bit of bruising on the posterior elbow and pain with range of motion. Again, trying to hook that tendon in the antecubital fossa, which will not be able to be done if this is torn. You can also compare to the contralateral side to see if there's any difference, if you're having any question about it. There typically will be quite a bit of swelling related to this, and this is an urgent issue that needs to get evaluated, so it's important to make sure you evaluate for that. On the MRI, you would see a hematoma in the torn tendon with typically some retraction. Other traumatic injury we see would be the ulnar collateral ligament injury. This is on the medial elbow. Again, like I said, the milking maneuver is a common procedure. Let's see if I can show this here, but you basically hook the thumb here, and then you maneuver this out this way, and any reproduction on the medial side of the elbow would be positive for potential either tear or strain of this ligament. MRI would show the disruption of the ligament on that. Sometimes, in order to see this a little better, you do also have to get an MRI arthrogram, so it helps to know what you're looking for as far as what you're ordering on your advanced imaging modalities. So treatment for the distal biceps tear really initially just would be ice compression. I'll sometimes put them in a sling for comfort, and then really getting an MRI and proceeding with surgery if that's definitively diagnosed. Really this needs to be done pretty quickly within the first 2 to 3 weeks after the injury. So it's important to keep that in your differential diagnosis. Ulnar collateral ligament, a lot of times you just want to avoid the valgus stress. It's very dependent on the level of athlete that you're dealing with. Typically, as far as surgical repair, it's not undertaken unless the patient is having a high level of competition. So typically we treat these non-operatively. They do make a hinged elbow brace similar to a hinged knee brace that you can apply that basically supports that side. And then there's some considerations of prolotherapy, PRP, to help institute some healing of that as well. And return to play is very variable just depending on if it's treated non-operatively or surgically. Common overuse injuries that I see fairly often would be the lateral and the medial epicondylitis. So lateral epicondylitis would be the tennis elbow. The medial epicondylitis would be better known as the golfer's elbow. Both of these are typically overuse injuries that we see. Sometimes if you hit something with a golf club, it can develop that medial epicondylitis. Again, it's really going to be a palpatory finding. They're going to be quite exquisitely tender over the lateral epicondyle or the medial epicondyle, depending on which one you're dealing with. And then they will typically have pain either with resisted wrist extension or wrist flexion. So I basically have them have them put basically their wrist down, and I'll have them push up against my hand, and that will typically cause pain in the lateral epicondyle, or I'll have them push down with their hand to check those flexor tendons there. X-rays here are going to be normal. You can see some calcific tendinitis in this area as well, so that may be some finding as far as causative of pain. MRI, you're going to see that the tendon's either partially torn or that there's just inflammation or tendinitis. Treatment here, so we talk about, again, ice, anti-inflammatories, stretching maneuvers. With lateral epicondylitis, I always tell patients that once you get this is going to be something that you're going to have to deal with. Typically, over and over again, you're just more prone to getting this again once you've already had it. So a lot of times by the time they've come to me in my office, we're talking about injections, which I actually utilize an ultrasound to inject here. I talked some to the patient about the chronicity of the injury. So if this is something that just occurred, more of acute tendinitis issue, then that's one thing. But a lot of people have developed these chronic medial and lateral elbow pain where they've had this pain, ongoing for sometimes even over 6 months. And really at that point, the tendinitis has turned more into a tendinopathy. And so I actually do some, basically a tenotomy with my 25 gauge needle when I'm doing this injection at that lateral epicondyle insertion to try to basically stimulate a healing response as well. Really, surgery is a very last resort in these issues because it's just not always a great outcome for these patients. So we really try to exhaust all conservative management. As far as bracing goes, I use a counterforce strap. So it's a little strap that wraps around the proximal forearm. You can position that either over the common extensor tendon or the common flexor tendon to depress that to basically alleviate the pressure on those epicondyles. For these also, you can also utilize a wrist brace, which basically is keeping the patient from flexing or extending their wrist, which will, in a sense, keep the tendons from being inflamed as well. I also discussed with patients some stretching exercises to both stretch out the tendons and elongate that so there's not so much pressure onto the insertion sites. Moving down into the lower extremity, we'll take a look at the hip here. So again, kind of like with the other joints, talk about palpation. So here's kind of a bony representation of the pelvis. See several of the structures here. So talk about the greater trochanter of the femur, which is a common site of pain. And I always talk to patients about hip pain. Hip pain seems to be a very broad complaint for patients. So what I tell physicians to do is to basically break this down into kind of 3 compartments. So typically patients will either come in complaining of hip pain that they'll have in the anterior groin area. They'll have a hip pain that they're experiencing on the lateral hip, or they'll have a hip pain posteriorly that's in the back part of the gluteal muscles or in the pelvis. And that kind of allows us to break down potential diagnoses as far as where their pain is coming from. So further on the palpatory examination, you can palpate the anterior superior iliac spine, ischial tuberosity, iliac crest, and the IT bands. Now, I always kind of take a aside here as well. So in your pediatric populations, it's very important to evaluate the insertion sites or the origination sites of the muscles in the pelvis that go down into the legs. So palpating over the anterior superior iliac spine, the inferior iliac spine, even into the ischium, just as far as where these muscles attach, because a lot of times these will be some types of avulsion injuries where you'll need to evaluate or offload the patient further. So the pediatric evaluation or adolescent population is a little bit different when they complain of hip pain. Range of motion, so we talk about flexion, which is typically accomplished by the iliopsoas muscle. That's your hip flexor, about 0 to 140. This is a fairly common cause of pain in patients in the anterior groin. It's typically a tight muscle group, especially in your active population. Extension, which is mainly achieved by the gluteus maximus, is about 0 to 10 degrees. Adduction, or to the body, is achieved by the adductor muscle group, which is typically about 0 to 30 degrees. Abduction, or away from the body, would be the glute medius and the minimus, which you normally see about 0 to 45 degrees, and then internal rotation with the gluteal medius and minimus, and the adductors about 0 to 40 degrees. And then there's 6 muscle groups that participate in the external rotation of the hip, and you can see those listed here, and typically expect somewhere between 0 and 40 degrees. For internal and external rotation, I typically evaluate that with the patient supine. I'll flex the hip up to about 90 degrees, and then I will internally and externally rotate the hip at that location. Some special tests when evaluating the hip. So you talk about the fader test, or the flexion, adduction, internal rotation. So this is looking at femoroacetabular impingement. So basically the test names itself. So you have the patient laying supine, you flex, adduct, and internally rotate their leg. And if they get reproduction of anterior groin pain, that would be a positive finding. There's also the Patrick's test, or the Faber test, which is flexion, abduction, external rotation. So again, this is typically seen with a positive in people with hip pathology, whether that be impingement, labral tears, even hip arthritis will have some pain with this. And then also it's helpful because if you get some contralateral pain in the posterior pelvis or hip, it could also indicate SI joint dysfunction. Log roll tests, again, the patient would be supine, basically just rolling their leg back and forth. And if they get clicking or popping, that could be indicative of a labral tear. People with advanced hip arthritis will also have a positive test with this as well. The Thomas test, which checks the hip flexors, that's where you have the patient lie on their back and then take the legs off the end of the table, and then you will have them flex and grab onto their one of their legs, and if the contralateral leg pulls off the table, that would be a positive finding. And then the Ober's test, which is evaluating the IT band. I typically have the patient lie on the unaffected side, and then I bring their leg abducted and I internally rotate it, and then I push down, and if there's reproduction of the pain in that lateral hip, that would be a positive test. So some traumatic injuries that we see in regards to the hip. So really the most common cause, as far as if they're complaining of anterior groin pain, typically would be an adductor strain. So again, they'll kind of have pain in the anterior groin. Usually occurs after some type of acute onset injury, lateral lunge type maneuver. It's typically the patient will be tender palpation, the pubic tubercle or the adductor tubercle, which is the area where that muscle encompasses. Typically don't need an x-ray. Again, like I said, we usually always get x-rays on people for further evaluation. Then if it's chronic pain that you're suspicious for a tear or some other issue, you can get an MRI as well. Another common traumatic injury would be the hip pointer. So basically this occurred in contact sports, so direct contact to the iliac crest. There'll be a contusion. There'll typically be bruising. It'll be rather painful, and you do normally get an x-ray with these just to make sure there's not a fracture. And then really it's just MRI is not really indicated unless there's a concern for a growth plate injury. Adductor strains typically do really well. It's just rest, ice. You can offload the lower extremity if they're limping with crutches, sometimes some deep tissue massage and strengthening, and a lot of times players or athletes get back in 0 to 6 weeks with these. Hip pointer, really just eyes. There's a shield that the player can utilize when he's playing, especially if he's a football player, to avoid having this occur again. And then some stimulation or anti-inflammatories, usually return to play within 0 to 3 weeks here. Moving on to the overuse injuries that we see in the hip. So we talk about kind of the spectrum of femoral acetabular impingement and labral tears. So again, this is going to produce a deep groin anterior hip pain. A lot of times they will have some mechanical symptoms, which would be locking, catching. Sometimes they feel like it's giving out on them. Again, the exam will have positive findings as far as that flexion, adduction, internal rotation, as well as the Faber test. And then the x-rays are somewhat important here because you can evaluate for certain anatomical setups that will put patients at risk for developing a pain with these issues. So typical evaluation would include an AP pelvis, and then also specifically to look for impingement, you'd want to get what they call a done view, which lets you look at the femoral neck and the acetabular ring, so you can see if there's a overhang or a cam or a pincer lesion. So typically with impingement, we're talking about a cam lesion. That's the most common. Cam lesions are where you're going to see a little bit of an extra growth over the femoral neck and the right at the junction where the head begins, the femoral head. Basically, there's an extra bony prominence, so when they put their hip through range of motion, it kind of rubs against that the hip there and causes pain. The other one would be a pincer lesion. That's basically where you have an overhanging of the acetabular portion of the hip joint, and that again kind of causes that grabbing sensation or pain when they run through motion. You can also have a mixed type where people have both a cam and pincer lesion, and again, this is something that you can see on x-ray. Other common overuse injury is a snapping hip. So a lot of times you'll have patients come in that are just saying that feel like their hips popping or snapping, and this is usually accommodated by some type of tendinous issue. So there's whether it be the iliopsoas deep in the pelvis, also the IT band can cause a snapping hip. So it's basically that tendons rubbing over one of the bony tubercles and causing this popping or snapping sensation. Evaluation for that, you do basically a dynamic test. So you take the patient from flexion, abduction, external rotation, and move them to a flexed, adducted internal rotation, which will typically either have them reaccumulate with that popping or snapping noise, or it'll also cause some pain. And again, x-rays would be the same. Treatment really, so for the impingement, labral tear, we initially treat the same, so it's really just a good round of core strengthening, hip strengthening and flexibility. So we utilize that in our rehab and try to strengthen up around the hip joint to prevent the pain from that. And typically these patients can return to activity without any issue. Now, if the pain persists or they're still having quite a bit of symptoms, you can get an arthrogram, an MRI arthrogram of the hip to evaluate more closely for the labral tear there, and then or you can also do a diagnostic therapeutic injection of steroid for this to see if that improves their symptoms. Typically what I'll do as far as the injection goes, I'd send them down to have that done under fluoroscopic guidance, and then I ask the patient to keep a diary of their pain, basically immediately following injection, and then I see them back typically 2 to 3 weeks after the injection to see how they are doing and have them keep a journal on to how their pain feels each day until I see them back. Now with the snapping hip, again, this is really just a rehab type thing, so we work on hip extension and stretching. Typically it's not anything that would keep somebody out of play, so it's really a quick return to play as far as that goes. Moving down into the knee. So again, palpatory examination. I break the knee down into basically 4 areas. So you've got the anterior, posterior, medial, and lateral, and there's obviously several structures in these compartments that you'll want to evaluate. And also this helps you kind of guide your knee exam as far as where the patient's complaining about their pain. So in the anterior compartment, we talk a lot about the patellofemoral joint. And then you've also got the quadriceps tendon, patella tendon, which is all in that anterior extensor mechanism of the knee. And then also the tibial tubercle where that patella tendon is attaching. Posterior, look at the popliteal fossa. Obviously, there's the hamstring tendons are crossing the knee back there. You've also got vasculature. A lot of times you'll be able to palpate a Baker cyst or popliteal cyst in patients. And then moving medially, you've got the adductor tubercle, the medial epicondyle of the femur, the medial condyle of the tibia, and then the medial collateral ligament. Also palpate the medial joint line as well. Laterally, similar structures that we see on the medial side, plus the head of the fibula. Range of motion with the knee, so flexions obtained by the hamstring muscles. This is going to be typically 0 to 130 degrees would be a normal range of motion. So I will typically denote their flexion ability. A lot of times with patients with knee effusions, you may not be able to flex past even 90 degrees. Also would document if patients have pain with terminal flexion when we flex their knee backwards. Extension is mainly obtained by the quadricep muscles, and again 120 to 0 degrees, and sometimes patients even have some hyperextension. You can document that as well. Testing of the knee, so we're looking at several structures here again. So the patella, so talking about the patella grind test, so we're looking at patellofemoral syndrome. You can also get a spectrum with chondromalacia, which is irritation of the articular cartilage of the knee. Would also show similar findings. And then the J sign, which we've seen patella maltracking. So you take the patient's knee and you flex it, and you'll start to see that patella track laterally the more you go into flexion. The patella is meant to sit between in the trochlear groove there, and so there's a lot of people that have tracking abnormalities where their kneecap will sit further out laterally. Sometimes this is due to a muscular imbalance. Ligaments, obviously important to test, so there's several tests that we look at here. One would be the Lockman's test for ACL stability. It's where you flex the knee about 30 degrees and then apply an anterior force on the lower leg and checking for laxity. You can compare this to contralateral side. The other one evaluating the ACL and the PCL would be the anterior and posterior drawer test. That's where you have the patient bring their foot flat onto the table and then apply a anterior force from the back of the lower leg and feeling for any laxity that you can document, and also an endpoint. So some patients will have laxity with an endpoint. If there's a full tear, however, there typically will not be a solid endpoint that you're able to garnish from that exam. Patients also guard quite a bit with this, and it's really important to have them relax their hamstring tendons when you're evaluating this. And then for the medial and lateral collateral ligaments, obviously the varus and valgus stress testing. Meniscus, there's several tests you can do to evaluate this. McMurray's test is where you have them laying supine. I flex the hip up, and then I will basically try to pinch the meniscus by internally and externally rotating the foot and then extending the leg. Apply compression is done with the patient laying prone and basically pushing the knee joint with the same maneuvers. And then Thessaly test, the patient's standing, they go up on their toes, and then they rotate through the knees. And then positive pain or clicking or popping, locking, when you do those maneuvers would be a positive finding. I will touch too, meniscus, really the main, most common exam finding is actually going to be joint line tenderness, though, so that's why I do make sure I palpate the medial and lateral joint line as well. Briefly, the Ottawa knee rule. So this is when should you get an X-ray? So the guidelines would say, 55 years or older if they have tenderness at the fibular head, tenderness at the patella, especially if after a fall. If they're unable to flex their knee greater than 90 degrees, or they can't bear weight immediately, or in the emergency department or in your office there. Let's talk about traumatic injuries. So basically, these would be injuries to the ligaments. So talking about the ACL, PCL, and then the medial and lateral collateral ligaments. Typically, there's going to be some type of injury or twisting mechanism that occurred. A lot of ACL injuries are non-contact, so there's some type of pivot shift maneuver that made that able to tear. They're going to have, typically, with all these injuries, immediate onset of pain, typically going to be limping or have some gait abnormality. Really, an exam would just be to rule out fracture. When we talk about the medial and lateral collateral ligaments, common type of injury with that is either a blow to the inside or the outside of the knee, and then you grade those 1 to 3 based on your exam findings. So you evaluate the patient both at 0 degrees extension and 30 degrees of flexion. And so if they have laxity at those 30 degrees, it's going to be typically a higher grade 2 injury, and if it's even showing laxity at 0 degrees, that's where the joint seems to gap. When you stress those, that's going to be a high grade, potentially a full tear of that ligament. And then that occurs with both the medial and lateral collateral ligaments. On the anterior cruciate ligament, the posterior cruciate ligament, it is important to get MRIs to confirm the diagnosis, and then also if you're having your higher grade, specifically the medial collateral ligament injury, if I have a grade 2 or higher suspicion on clinical exam, I will get an MRI to make sure there's no other subsequent injuries. You will typically see some ACL injuries and meniscal tears with this as well. ACL, typically in most individuals would be surgery, and return to play is minimum 6 months, sometimes longer than that. Posterior cruciate ligaments really rehabbed more. They don't operate on these as much, and so it's more of a rehab bracing, and then you can typically get back to play a little quicker in that 1 to 6 week mark. On the collateral ligaments, so again, we're talking about the testing and then the grading. So it's important to evaluate these in your office. Most grade 1 and 2 injuries can be treated conservatively. So that's with the ice compression. I put patients in a hinged knee brace to protect the medial and lateral components, and then basically your return to play guidelines would be based on their pain and functioning as far as their strength on their knee. So basically, it's nice to have 2 legs. You can compare that to the contralateral side and evaluate that further and release them once they're able to get to that point. Grade 3s, like I said, again, you're going to start getting concerned of some other subsequent injuries with ACL, so you're typically MRIing these patients and referring for orthopedic evaluation. Overuse injuries in the knee, so really the most common cause of pain in general, as far as the knee pain comes in, is patellofemoral syndrome. They're going to have anterior knee pain. They'll have a positive patellar compression test. There typically is not an effusion unless they're starting to develop some of that more significant chondromalacia of the articular cartilage. X-rays would be normal. My typical X-rays for a knee is AP lateral. I get a weight bearing to evaluate for arthritic change, and then also a sunrise view. So that sunrise view is very nice to evaluate this patellofemoral joint, so you can kind of see if they have any lateral tracking or arthritic change in that joint. You do not need MRIs for this. It's treated conservatively. Jumper's knee, so another overuse injury. It's kind of localized pain in the anterior knee. X-rays are going to be normal, and then really not needed an MRI as far as evaluating that patella or quadricep tendon there, unless it's a severe case that's not responding to treatment. So again, this patellofemoral pain syndrome is really the most common overuse injury we see. Literature would state that NSAIDs are much more effective than steroids, and then there's an array of different patellostabilizing braces that you can utilize, and then really VMO strengthening is the key as far as from a muscular and balance standpoint. This is focused on that vastus medialis obliquus muscle, which is on the medial side of the knee, and typically a weak muscle for patients. And then really, surgery is not considered until there's been a year of conservative treatment. So, and these are some of the VMO strengthening exercises. You can kind of read through those on your own. A lot of single leg activity, even a stationary bicycle is good for these type of exercises. Jumper's knee, so it's that patellar tendonitis, Again, really just ice, rest, anti-inflammatories. I, again, use that counterforce strap like I talked about in the elbow for this. It tends to work pretty well. And really physical therapy to work on quadricep strengthening and the hip flexors. And then, if it continues to bother them and you do get an MRI and you either see some partial tearing or, chronic tendonitis, tendinopathy changes, then potentially could have some surgery, but really would want to fail numerous conservative measures. And then lastly, moving down into the ankle, again, talking about palpation here. So you want to palpate over the anterior aspect of the ankle, posteriorly in the Achilles and the calcaneus, then the ligaments of the ankle on the medial and lateral portions. So you've got the anterior talofibular ligament, the posterior talofibular ligament, calcaneofibular ligament. Medially, you'll have the deltoid ligament, and then obviously over the medial and lateral malleolus. Range of motion, so plantar flexion typically is about 0 to 50 degrees for patients, and then dorsiflexion would be 0 to 20 degrees. Dorsiflexion is typically a weak area for patients. Usually most can get to about 0 degrees. This will typically cause a lot of issues with plantar fasciitis and Achilles tendonitis if you have a poor range of motion in regards to dorsiflexion. Testing of the ankle, so we talk about the anterior drawer test, which is testing for the anterior talofibular ligament, the talar tilt, which evaluates the calcaneofibular ligament. Those are the two most common lateral ankle ligaments that are injured in ankle injuries. Thompson's test, which tests for the Achilles, and then the squeeze test for high ankle sprains. So anterior drawer test is performed by holding the patient's ankle and then trying to translate the foot forward. If there's laxity, that would be, or pain, that would be a positive testing. Talar tilt's done by palpating the foot and then inverting and everting the foot, and if they have pain reproduced with this, that would be a positive finding. Thompson's test, typically I'll have them lay on their stomachs with their knee flexed, and I will squeeze the calf muscle, and if you're looking for the foot to plantar flex when you do this, and that would be a negative test. So that's what you would want to see. So if you don't see that, then you're concerned they may have torn their Achilles. Squeeze test is done for high ankle sprain. Basically, you just move up into the distal lower leg and then squeeze around that ankle, and that's typically seen in more your higher ankle sprains. I'm sure we all remember these, the Ottawa ankle rules. So, if you get basically the indications for x-ray, so if there's pain in the medial or lateral malleolus, and then you have any bony tenderness over those areas, and you're unable to bear weight immediately or in the emergency department, x-rays would be indicated. Talking about ankle sprains, so really most ankle sprains we see are going to be on the lateral ankle. ATFL, anterior talofibular ligament, is going to be the most commonly injured. They will have pain over that ligament. There will be swelling. Moving into higher grade ones, they'll also start getting issues into the calcaneofibular ligament and the posterior talofibular ligament. Like I said, medial sprains would be involving the deltoid ligament. Grade these 1 to 3. They're basically all treated the same. So my initial treatment is kind of based on the patient's presentation. If they're limping, I will offload them in a boot, potentially crutches if they're continuing to limp in that, and then follow up with them in the office in 1 to 2 weeks. Really, boot wear is, you try to minimize as much as you can, because the longer you're keeping a boot, the worse their range of motion is going to get. So you really want to evaluate these people somewhat quickly after you've seen them in 1 to 2 weeks to see how their pain is doing. As far as ligament disruption in the grade 1s, you don't have any. Grade 2s, you start getting a stretch, but you don't have a tear. And then grade 3, you have a complete tear of the ligaments. Grade 1s, your swelling would be minimal to mild. And then grade 2s, you'll typically get more moderate. And then grade 3, severe. And then pain. Again, the grade 1s, sometimes these people can even walk on these. And then grade 2s, they may be limping. And then 3, they may not even be able to bear weight there. So treatment, like I said, get an x-ray, and then all our prise, protect, rest, ice, compress, and elevate. So then we also consider a short offloading course, like I said, for about 1 to 2 weeks with a high-tide cam walking boot. Typically, once I see them back in the office, they're improving, their pain's improved, their swelling's going down, I will transition them to an ankle support orthosis or an ASO brace. This fits into their shoes, so it's a little bit more tolerated. and then early physical therapy is indicated. So I usually try to get them in physical therapy as quick as I can. Now, MRI is only really indicated if they're not responding to conservative treatments for all grades. So again, like I said, if initial treatment would be the same as long as there's no fracture, and then just continual reevaluation. And then return to play guidance would be based on the severity of the injury. Grade 1s, sometimes they can get back in a week to 3 weeks, depending. 2 sometimes takes 2 to 4 weeks, and then grade 3s 5 to 8 weeks. Another overuse injury would be one of the overuse injuries would be Achilles tendonitis. So those patients will have pain in the posterior heel down at the insertion of the Achilles on the calcaneus. There'll be swelling. Some x-rays may show a bone spur down there, and then MRIs will evaluate if there's an extensive degree of degeneration or, again, a tear if you're worried about that. Treatment for these, usually I'll talk to the patient about heel lifts. I'll put a heel lift in their shoe, foam rolling on the calf and the Achilles, and then also physical therapy. And then usually patients with this will improve at 2 to 4 weeks. Surgery's, rarely indicated, and then there's some evidence as far as prolotherapy and platelet-rich plasma in treating these issues. And then one other thing that has been shown is a nitroglycerin patch over the Achilles as far as from a pain relieving standpoint. Very happy to talk with you today. I'm glad we could discuss some of these common sports injuries. I hope this has helped you in your practice. And if there's anything I can do to assist you or anything, definitely get in contact with me. I'd be happy to help you. Once again, thank you very much, and I hope you guys have a great day.